Thanks so much for having me today. My name is Adam Faye. I'm actually a advanced inflammatory bowel disease fellow currently at the Mount Sinai Hospital in New York City. And this was a study that we actually did during the height of the pandemic last year. So in addition to some of the frontline work, we were very interested in really understanding how COVID-19 wasn't going to impact our patients with immune-mediated diseases and our patients with autoimmune diseases. And there have been some registries set up, but particularly we were interested, what about the patients coming to the hospital? What about those patients who were sick enough to come to the hospital with immune-mediated diseases? Did they actually have worse outcomes than patients who didn't? So this was kind of what prompted the study. So what we first actually looked at was basically presentations of illness. And by that, we looked at vital signs of patients coming in with immune-mediated diseases versus patients without immune-mediated diseases. And what we did was we took 186 patients. We actually took 62 patients with, I'll call autoimmune or immune-mediated diseases, and age and sex matched them to 124 control patients, all of whom were admitted to the hospital. And then we looked at their ER. So we actually had granular level data, not just survey data, but we could look at outpatient medications, inpatient medications, all their vital signs, laboratory values. And we basically looked at all that data. And what we found was that the patients who had immune-mediated diseases were not coming in with any differences in their vital signs, meaning they didn't appear to be sicker when they hit the emergency room. We looked at oxygen requirements, heart rate, blood pressure. We also looked again at labs like ESR, CRP, IL-6, procalcitonin, so all those inflammatory markers. And then what we did was we followed them throughout their hospital course. Again, we tracked their inpatient medications as well as their outpatient medications. We tracked their comorbidities, their smoking, and we looked at some of the outcomes. So if we take a look here, our primary outcome was actually looking at a composite of intubation, ICU, or death. That's what we really cared about. Were these patients with immune-mediated diseases, were they coming in and getting intubated more often or dying more often, or going to the intensive care unit? And actually what we saw on conditional logistic regression was that having autoimmune disease or immune-mediated disease was not actually associated with worse outcomes. And on univariable, looking specifically at intubation separately from ICU and from death, we actually saw the same thing. And when we also looked at a Cox proportional hazard model, so we said, okay, maybe there's not a difference in overall outcome, but maybe patients with autoimmune disease actually died quicker in the hospital or had worse outcomes earlier on. And what you can see from this graph is actually that the patients with autoimmune disease actually did not end up having worse outcomes earlier within their course at all. So this was at least very comforting for us in the early days. Again, this was during the height of the pandemic. We were struggling to really understand how it was affecting our patient population and what to be recommending. So from this, there were a couple of questions that I think have come out. So I've been asked, do you feel the study is of adequate size and the results can be replicated elsewhere? It's a great question. Again, we had 186 patients, only of which 62 had immune-mediated diseases. It was tough, especially in the early days, to get a cohort of patients that were hospitalized with autoimmune or immune-mediated diseases. So we were obviously limited by that. And what we did was we actually grouped a couple of different immune-mediated diseases together. So rheumatologic diseases, I'm an inflammatory bowel disease expert, so we put inflammatory bowel disease in, sarcoidosis, all of those. The literature has kind of supported this. A lot of the literature comes from some inpatient but more outpatient data and suggested that patients with immune-mediated diseases as well as those on biologics and other therapies may not be at higher risk. Although again, there is some data showing that perhaps they are at a higher risk. And some of the more granular details suggest that maybe corticosteroids or immune modulator therapy, azathioprine, 6-MP, medications like that may actually pose higher risk for patients, at least in the outpatient setting. What we did was we actually did a power calculation to get a sense. Well, the question really that we were hypothesizing is maybe our patients with autoimmune disease, they'll have this increased cytokine response and they may be at higher risk. So when we looked at the power calculation, we actually had power to detect an increased risk of about 1.72 odds ratio. So what we could at least say is that it does not appear that the patients with immune-mediated diseases have higher than a 1.72 odds ratio of having a worse outcome. Other questions I've been asked is, as a physician, how does this study influence your patient conversations regarding current medications and vaccinations? I think this is really a crucial question and something that we were struggling with in the beginning of the pandemic. We had a lot of patients with inflammatory bowel disease, rheumatologic diseases, stopping their medications. We didn't really know the impact that they would play. At this time, we're really encouraging patients to stay on therapies. Obviously, if they're acutely ill with COVID, we hold in that kind of acute time point, but much more if they potentially have an exposure, but they're otherwise well, and their COVID's been negative, even if their family member that they maybe saw a week ago is positive, we're encouraging them to continue on these medications because at least from the data we have and from what's coming out in the literature, it seems that they're not at higher risk for adverse outcomes from that. Again, I will suggest that immunomodulators and steroids are a little bit different, but when talking about biologic therapy, what by that, adalimumab and infliximab, things that traditionally we put our patients on, we don't see that increased risk. What about the COVID vaccine? This comes up a lot. So I think the interesting questions with the COVID vaccine are, obviously our patients with immune-mediated disease are being prioritized. I think that that's wise considering a lot of them are on corticosteroids or immunomodulator therapy. And again, that might be higher risk. We also, there is also data suggesting that possibly some of these patients are at higher risk. In our study, what we did was an inpatient cohort. And again, we kind of grouped a lot of inpatient diagnoses together, again, sarcoidosis, rheumatologic, inflammatory bowel disease, in order to get a cohort that we could really power for this study. So I do think there needs to be individual disease-specific studies that we can actually look at. Another thing with the vaccine is response to it. And that's something that's actually ongoing right now. So specifically patients with inflammatory bowel disease, I can say they've looked at flu vaccine studies and they do seem to mount a good response. Although there was a recent study looking in the transplant literature about patients on immunomodulator therapy, and perhaps they don't mount such a robust response as some other patients. So we'll have to see. We're collecting current data right now. Hopefully we'll have that soon. Regardless, our patients should be getting the vaccine. The only thing we say with timing is that perhaps you shouldn't get it on the same day as maybe you're going to inject a medication like a biologic, et cetera. In case you have a reaction, it's probably better that we know, is this a COVID vaccine or is this from your medication? The other quick point I'll bring out is that based on data, at least with an inflammatory bowel disease and the flu vaccine, it doesn't matter in terms of where you are in your cycle of medication in terms of getting it and response. So you can be rest assured you should be able to get it at any point throughout the infusion or throughout your cycle. Again, would just recommend trying to avoid on the same day just in case there's side effects. One other question I've been asked is, do you think this study is telling of the impact of JAK inhibitors, TNF inhibitors, and DMARDs on viruses? It's a good question. It's a little bit hard to say. Each medication has a different side effect profile. I know most of us are pretty familiar with the JAK inhibitors and zoster and the shingles risk. In terms of other viruses, it's a little bit difficult to say. Again, it's probably patient population and drug specific to that. But at least in this study, it seems that being on biologic medications and some of the larger outpatient registry data have suggested that being on biologics and other medications like small molecule inhibitors may not increase that risk. Again, I'll just reemphasize, maybe corticosteroids and immunomodulators might be in a separate category. And then lastly, what else would you need to be done to prove or disprove medications make patients at a greater risk for infection? So I think this is a great question. So our study, it was a retrospective single center study. Obviously following patients prospectively would be great. And then really, as I mentioned, not in our study, we have a broad array of diagnoses to really power it so that we could look. But actually looking at the individual diagnoses, so someone with Crohn's disease versus someone with sarcoid versus someone with lupus or rheumatologic disorders such as RA, looking specifically at the different disorders, I think would be much more telling, and something that now that, unfortunately we've been dealing with this pandemic for a year, we should have the data to start to look at more robustly. So with that, I'd like to thank you for your time and for listening, and hope to see you all soon and that everyone's safe and well.